quieres, ya puedes iniciar. Ya estamos transmitiendo.
Okay. Buenos días para todos las personas que nos están viendo en diferido. Les damos la bienvenida al primer Congreso de Cuidado Crítico de la Clínica Los Cobos Medical Center en asociación con la Clínica MAYO. Vamos a iniciar con nuestro conversatorio acerca de ecocardiografía en cuidado intensivo y para ello nos acompaña el doctor Sunil Mankat, que es especialista en medicina interna, medicina crítica, medicina cardiovascular y ecocardiografía. Es miembro del American College of Cardiology, la American College of Chest Physicians y la American Society of Echocardiography. Gracias.
So, Dr. Mankat, we are very pleased to have you. We would like to have a brief introduction on how do you feel and how do you focus your expertise on the different protocols that Mayo Clinic use to make Pocus possible on all echocardiography on different systems. So we'd like to know your first impressions on that.
So I think Pocus is still growing, but it's so important in many different areas of critical care. First, in the patient who's hypotensive, you can assess the heart, cardiac, the vasculature, and that's very important. But in addition, knowing what's happening in the lungs can help you decide about fluid resuscitation. So all are important and aspects of Pocus. Then in the patient who's just dyspneic, it's so important to differentiate between pneumonia and heart failure. And this can be, Pocus can be very helpful. It is as good as diagnosing a pneumothorax as is CT scan or X-ray. So hypotensive patient, dyspnea patient, and then of course the patient in shock, because until you have what we call the shock phenotype, you don't know how to treat the shock. And the clinical assessment can tell you the patient's warm or cold. We know the patient may be in shock due to acidosis, lactic acidosis, and low blood pressure, but you need to see the heart to really know the shock phenotype. Is it an RV, right ventricle problem, or a left ventricle problem? So very quickly, the heart, the lungs, and then the vasculature is mostly for us cardiologists and is the inferior vena cava. Although certainly you can look at other areas as well.
Just briefly to get more details on that answer, can you describe how would you focus your the steps either for an emergency department situation that goes into the OR and then to intensive care? How would you think that will be the most appropriate steps on focusing Pocus practice for that?
So in the United States, Estados Unidos, there are different levels of Pocus. At the basic level, for our emergency room and many ICU doctors, it is just to understand the heart function. Is it normal or abnormal? But then many anesthesiology critical care physicians do a more advanced assessment of the heart, and they can tell filling pressures within the ventricle. And so there's different levels of training. Most ICUs in the United States have their own echo machine. It's not a full cardiac machine, but rather more of a Pocus machine. But it has 2D echo, color Doppler, and spectral Doppler. It may have tissue Doppler, it may not, but each ICU will have its own machine. Each emergency room will have its own Pocus machine. And we all work together. We as cardiologists provide some degree of quality control over the ICU doctors and the emergency room doctors.
On that specific question, I would like to know, when you review a patient that's been on the OR, on the emergency room, then on the OR, and then on the intensive care. Then you have, as I understand, some professionals that are not cardiologists, but they do Pocus, right? We call that the credentials, right? How does Mayo Clinic manage that? Like, how do you certify
Right.
that the specific focus that somebody that is not a cardiologist has done, it's good enough to make good and critical decisions?
The most important thing is any institution, the images must somehow be stored to be reviewed. So for instance, our emergency room and critical care doctors, they will do the POCUS exam, and then they won't generate a report, but in their note, they will describe what they thought the left ventricle was, what they thought the volume status of the patient was, what the lung ultrasound showed. But then it will always be there, the images, to be reviewed later. So then, for instance, if the patient needs a full echocardiogram, cardiology echocardiogram, then we would perform that in cardiology and generate a report. But the emergency room or critical care physician has done their POCUS exam. The images are all available for review by everybody, and in their note, they describe what the findings were. They don't separately bill for the echo, charge for the echo, but they do charge for critical care time doing the echo. And that's the general principle. Now, obviously, if they need, they go to the operating room, they may get transesophageal echo. That's the separate issue. And then they do generate a report for that.
Doctor Mancan, teniendo en cuenta lo que nos acaba de mencionar, digamos, de los diferentes niveles de entrenamiento que tenemos para la realización de ecocardiografía en nuestros pacientes críticos, tanto en el área de emergencias como en la unidad de cuidado intensivo, es importante hablar, digamos, de educación para los médicos en estas diferentes áreas. ¿Cómo considera usted que podemos implementar estas estrategias de educación, teniendo en cuenta que nuestra sociedad, nuestro medio todavía es un país en desarrollo, para implementar estrategias que sean prudentes en este contexto?
So if I understand the education of the POCUS and echo, so there's different areas for emergency room critical care doctors versus anesthesia critical care versus pulmonary critical care, different ways to get into critical care. Each has their own hierarchy or structure to educate. We as cardiologists provide lectures, but then the actual hands-on training is really the most important. So there is a given number of echoes and the different types of echo that must be performed and interpreted in order to complete their training in POCUS. Once they've completed that training, there is in the United States a certification in POCUS. It's by an organization, the National Board of Echo. They can provide this certification. But most important is not the certification, but the training, which includes lectures, and most importantly, hands-on and improving their skills so that they can get it. And working together with the different organizations and reviewing cases together to make sure that everyone is doing it correctly. But formal lectures, but more important is the hands-on training.
How do you achieve the quality control in the non-cardiologist practitioner? Do you do full? Do you review the 100% of the cases?
No. So the images are there for review. So if that patient has a formal study or we do an additional POCUS, we can certainly review the prior images with the person that performed the POCUS. But a small percentage of the cases, we get together 4 times a year and review with the different groups. For instance, the medical ICU doctors, we review their echoes periodically, but not all, only a percentage. But all the images are available for review. So if there is a discrepancy between the Pocus exam, let's say of the heart, and then a formal cardiac echo, we will have that difference and can communicate additional findings or revised findings. But the key there, once again, somehow is the storage of the Pocus images so that there's transparency and everyone can look at those images later and learn from it.
In your experience, what would you say is the most difficult thing that you have found in that area, like reviewing stuff? Like,
Well, I think the key is because many critical care physicians have to do so much, they may not have as much skill in echo, and sometimes they can maybe be overconfident in their interpretation. So the most important thing is, I think, knowing what you don't know and making sure that you use your critical care skills as a clinician in addition to just the echo.
Digamos que Iván nos va a traducir, teniendo en cuenta lo que nos ha comentado de tener en cuenta nuestras limitaciones en el conocimiento, en la práctica de ecocardiografía. En nuestras instituciones, lamentablemente, no tenemos un staff tan grande o no tenemos a disposición la ecocardiografía realizada por cardiólogos las 24 horas del día. Y es conocido bien por todos que generalmente las decisiones críticas las tenemos que tomar en la noche. Digamos que una pregunta importante para nosotros es ¿en qué momento considera usted que debemos llamar al cardiólogo especialista en ecocardiografía para esa toma de decisiones en nuestros pacientes críticos?
so while taking hard decisions and critical care specifics, we have a lot of scenarios that give us trouble, especially at night and during the weekends. But then we don't have cardiologists 24 hours. So this question is like corresponding to the last one. If you can give us some focus on what you find hardest for the intensive care clinician, what would you say is the proper time so that when the intensive care physician finds a problem, just call the cardiologist right away?
Well, I think certainly if you identify cardiac tamponade, large pericardial effusion, that would be one instant. If you have identified a significant change in LV function, reduction in LV function, and with confidence, you see a new regional wall motion abnormality. In other words, anterior wall or inferior wall being hypokinetic. And you're worried about ischemia or heart attack. Those patients, medicines may not be enough. Those patients may need to go to the cardiac cath lab or cardiac catheterization lab. And so knowing when to contact someone regarding that, a cardiologist, is the most important, I think.
On your expertise and your professional opinion, what would the time between the call and the actual assistance for a cardiologist at night and weekends?
Yeah, so I mean, I can only say what we offer at Mayo Clinic is certainly 24-hour echo. When patient has a cardiac arrest, there is a group of echocardiographers that are involved with ECMO. They can be there within 20 minutes. A cardiologist to do a transthoracic echo, maybe 1 hour, 60 minutes. But the transesophageal echo can be performed in maybe 60 minutes. But ECMO, 20 minutes. But that's where it's so important for anesthesiologists to have the experience, because they are here usually in-house at the bedside. So they need to learn how to use echo, both Pocus and transesophageal echo. If you do critical care, you need to know Pocus. It doesn't matter your background, whether it's emergency room, anesthesia, medicine, or cardiology. You need to learn Pocus because it's such an important tool to help you care for patients.
That's an answer. Thank you. I have one last question. We both go into a background of anesthesia. For our training, we've been said several times that we need to be able to perform a laryngoscopy for 40 to 60 times without help. Be achievable in that. What would be your answer for that in specific cardiac focus?
I would say in order to be adequate, satisfactory, you need to do at least 20 exams of Pocus. And then to be good, probably you need to do about 50 exams. But I'd say as a baseline, between 10 and 20 to gain the experience, and then maybe 50 to become excellent.
Thank you. That's all we were looking for.
Muchas gracias, doctor. A continuación, entonces, vamos a pasar a las charlas magistrales que vamos a tener en el auditorio principal y damos por terminado este conversatorio.
Thank you a lot for your time.